I currently work at a facility that is a long-term care residence for people with advanced MS. The general definition that we use is using the Kurtzke expanded disability severity scale ranking, which is 0 to 10 for anybody with MS, but almost everybody here is ranked between 8.0 and 9.5, which indicates that they have pretty severe physical disability. Technically, on that scale, they are considered quote unquote bedridden, although actually everybody here is pretty active in terms of what they can do on a daily basis. We have to use a lot of assistive technology to make sure that they can do whatever they can independently still do. Some of the most common items that are in use here are power wheelchairs with a lot of adaptive controls, even if people no longer have hand control to be able to use a typical joystick. They can use head controls or some other alternative drive mechanism. They might have access to relatively mainstream technology, such as tablet devices, smartphones, what we call environmental control units or ECU devices. And fortunately, a lot of those are now fully accessible via speech recognition. So regardless of the level of physical disability that people have, and this is not only true for the MS community, but for a number of people with progressive neurological disorders, they often have to use something that requires minimal to no physical contact as the disease progresses. As a speech and language therapist, I also do work a lot with people who also are having a decline in their motor speech intelligibility. So sometimes, there's the blessing of having technology available that is accessible via speech recognition, but there's also the curse of having difficulty with speech intelligibility. So a computerized interface is not always optimized for understanding people with atypical speech. So in one of the discussions that I was able to present at CMSC, we talked about a couple of options for modifying existing technology to make it easier for people who have atypical speech. So again, most people with MS, with progressive MS, tend to have, if they have anything with their speech, it tends to be a quieter voice, tends to be a slower rate of speech, and there tends to be some degree of difficulty with articulation. So we try to focus on those three areas as both a standard behavioral intervention, but then also applying it for improving the technology access that they might have. So for example, if projecting the voice is difficult, we may find a position to physically mount a speech recognition module close to the person's head so that it will capture as much of the voice as possible. We may also adapt the listening duration. So, many devices only give you a few seconds to initiate a command after you use the wake word, such as ALEXA, which I won't say out loud to trigger devices, or something along those lines. So you can adapt it to maybe listen for 5 to 10 seconds in case people need a little bit more time to respond after producing the original wake word. So with speech recognition, we talked a little bit about individuals who I also focused on people who were using tablet devices, more specifically iPads, which is the most common brand that we use here. So we did do a questionnaire with those individuals, developed in Canada, called the Quebec User Evaluation of Satisfaction with Technology, or the QUEST. And so it's essentially a 1 to 5 scale that people have. 1 being very dissatisfied, 5 being very satisfied, with different components of the technology as well as the service provided to deliver those, the device to the person, as well as ongoing follow-up modifications, upgrades, maybe what we call sometimes iterative design, where individuals may have the ability to access a device in one way. And then if their disease progresses and they have a change in their functional status, we may have to then go back and adapt their interaction with the device. Doesn't mean we change the device or change much of the way that they actually typically use it. It's just more changing the access method. So fortunately, most people were very satisfied on that rating scale. It averaged among 10 users who had at least a year's worth of experience with mobile technology. It was around 4.2. So again, fairly satisfied with the technology itself. The service delivery, they ranked at around 4, so pretty solidly satisfied with that. And then there are 12 parameters on that questionnaire that are posed to users in terms of what are specific elements of assistive technology that are important to you. And out of the 12, the 3 most important identified were the dimensions of a device, the weight of a device, and how easy the device is to use, which I think all of those are very relevant regardless of whether people have a physical disability or not, but definitely are very important for people who do have a physical disability, whether it's related to MS or some other condition, because they have to be very aware of the physical requirements to bring a device into the community or to bring it around whatever environment they typically are working in. So the dimensions and the weight relate to that, as well as understandably, people don't want to spend a lot of time getting onboarded with assistive technology. So if it's not particularly easy to use, almost right out of the box, there's not as much interest in it. So that's all been very good feedback. And I think it's also been very confirmatory for us that our focus on trying to adapt mainstream technology, meaning fairly commercially available devices, to meet the needs of people with pretty severe disabilities, has been more consistent with what people with disabilities want, as opposed to trying to implement something that may be a bit more customized or specialty equipment for this population. But if it's bulky, if it takes a long time to learn to use, or if it's not particularly useful for the person to use in different community or daily set environments, then it's not going to be particularly meaningful for people. So for me, it was really excellent feedback, having worked with this population for almost 15 years now, to see that the technology we've been investing in has really met the primary needs as well as the primary preferences of this population.